We present a robotic pancreaticoduodenectomy, or Whipple procedure. 16 comparative studies, including more than 83,000 Whipples, have evaluated robotic cases against open and laparoscopic approaches. Robotic cases represent only 3%, and no randomized trials have been completed to date. Series consistently show that major complication rates, 90-day mortality, and margin-negative resection rates are comparable to open surgery with similar outcomes against laparoscopy. Length of stay is reduced, lymph node harvest is equivalent to open and slightly higher than laparoscopic. Costs remain higher. Some studies have suggested a slight survival advantage, though these results are not universally consistent. Our patient is a 70-year-old male presenting with progressive abdominal pain. CT revealed a periampullary mass without metastatic disease. ERCP demonstrated a papillary lesion causing a distal common bile duct stricture and proximal dilation. Biopsy showed low-grade dysplasia concerning for malignancy, and a 10 French by 4 centimeter plastic stent was placed. Following tumor board discussion, the patient was scheduled for robotic pancreaticoduodenectomy. After a negative survey for peritoneal metastasis, the falciform was divided and the liver and gallbladder suspended with barbed suture for cephalad exposure. The gastrocolic ligament was divided with vessel sealer, carefully preserving the gastroepiploic artery and veins. A standard cochlearization was performed, mobilizing the duodenum and pancreatic head off the cava and aorta to the left lateral border. Arcade branches along the greater curvature were isolated and divided to complete the exposure. The duodenum was divided just distal to the pylorus with a blue load stapler. This pylorus preserving technique has been shown to reduce delayed gastric emptying in some series, although overall outcomes are comparable to classic Whipple. The posterior stomach was freed from adhesions, and a penrose was passed around the pancreatic neck over the portal SMV confluence. The jejunum was divided approximately 60 centimeters distal to the ligament of Treitz and mobilized retrocolic to the right upper quadrant for later reconstruction. After meticulous dissection, the gastroduodenal artery was skeletonized, looped with a blue vessel loop, and divided with an 8 millimeter white load stapler. The proximal stump was reinforced with surgical clips. The dilated bile duct was dissected free from the portal vein and looped. A bulldog clamp was applied proximally via the 12 millimeter assist port. The duct was divided sharply, and a barbed suture was selected for reconstruction due to the common bile duct's thickness and dilation. The pancreas was transected at the neck. The parenchyma was divided with energy, and the duct sharply divided with scissors. Then further dissected using electrocautery from above. Belcher's vein was identified during uncinate dissection, clipped, and divided until the pancreas was free and the specimen was passed off for retrieval. We then began our reconstruction with a modified Blumgart pancreaticoduodenostomy. 2 zero-silk U-sutures were passed transpancreatic to anchor the posterior capsule to the jejunal seromuscular wall. A small enterotomy was made, and the posterior duct to mucosa layer was completed with 4O PDS. A short internal pancreatic duct stent was inserted to drain into the jejunal lumen and pass spontaneously. The anterior ductal wall was closed with additional 4O PDS, and the interior capsule was reinforced with interrupted 3O vicryl. This layered approach provides precise ductal alignment and minimizes tension, particularly amenable to robotic suturing, which facilitates intracorporeal precision. The biliary limb was aligned and an end-to-side hepaticoduodenostomy was performed using 3/0 barb suture. Barb suture was chosen to maintain consistent tension and facilitate intracorporeal running technique, particularly useful in a thick dilated duct. A short stent was placed to maintain patency during early healing. The anastomosis was inspected with a Robotic and no leak was observed. Approximately 40 to 50 centimeters distal to the hepaticoduodenostomy, a single-layer end-to-side gastroduodenostomy was fashioned. The gastral staple line was opened with cautery, and the anastomosis was completed with a running 3/0 barb suture. Care was taken to ensure proper orientation of the biliopancreatic limb without twist. The mucosal edges were incorporated evenly to prevent narrowing, and tension was minimized by positioning the limb in a straight retrocolic course. This reconstruction confirms pylorus preservation using a gastroduodenostomy rather than a duodenoduodenostomy. In summary, we present a robotic pylorus preserving pancreaticoduodenectomy for periampullary mass. Final pathology showed a 7.2 centimeter tubovilus adenoma, margins negative and 0-14 lymph nodes involved negative. Operative time was 9 hours, blood loss was 20 milliliters. Drain amylase downtrended consistent with no pancreatic leak. Patient was discharged on postoperative day 6.